This Ask the Expert webinar is about asthma and allergy in pregnancy. It's something that comes up among the families who come to our clinic, and it's something that outside physicians call about with some frequency. So I hope to hit the high points, and I'm looking forward to questions because this is just a general thing to cover in about 20 minutes. So what we're all gunning for is healthy moms and healthy babies, and the incidence of asthma is really ghastly high. And that's why this is an important subject. So the CDC believes that 8% of adults have asthma and 7% of children, which when you think about it is a huge number of the population. And these people account for 1.6 emergency department visits every year, and 3,500 people die of asthma in this country every year. And the horrific thing about these numbers is that most of those visits and most of those deaths don't have to happen. So this is important. So asthma in pregnancy. So for many years, the idea was that among pregnant women, a third of women will have worse asthma when pregnant, a third of women will get better, and a third will stay about the same. And there have been some really interesting studies looking at gender of the fetus, whether or not that makes a difference, and that's really not anything conclusive. But one thing that's new, that's sort of a signal in a lot of new asthma papers, is that women whose asthma gets worse when pregnant, and this is not across the board, are women who are wary of exposing their fetuses to medications and so stop their medicine ahead of time. Okay, I was looking at the question, but it looks as if that's not an urgent one. So this is about asthma control in pregnancy. One thing that should be a given is that fetuses need oxygen to be healthy. And so pregnant people with asthma need their medicine. And there are some medications that are preferred in pregnant people and some that, we can do better with. So ideally, everyone who wants to get pregnant will have an up-to-date asthma care plan before becoming pregnant, but we all know that this is not an ideal world. And so if someone becomes pregnant, it's important to go see their doctor, whether it's the obstetrician, the primary care doctor, the pulmonologist, the allergy doctor, to see if there's a better approach. And again, one thing I would do in my outpatient clinic, if a young woman came in, I would say, are you planning on having a family? And she might say, well, in a couple years, or I don't really know. And the thing is, we could have that conversation about changing asthma medicines or keeping the current asthma medicines early, and at least the seed was planted. So the guidelines for gestational medication use, for a long time, and the reason we're really pushing medication now is that asthma medication is so safe and the benefits clearly outweigh any potential harms. But for a long time, we really only had oral steroids and epinephrine to manage asthma. In the 1960s, if you had asthma, it was Intal, it was oral steroids, it was epi if you got really bad. But for decades, we've had inhalers, and inhalers are safe because instead of talking about milligrams or grams of medication, we're talking about micrograms, and these are inhalers, so the medication goes right to the lungs. And many doctors will tell their patients that you rinse your mouth because it minimizes any risk of thrush, but it also minimizes the dose that you receive of these medications. So proper inhaler use is key. If you stretch your neck up, you're less likely to have medicine deposition in your throat. You can suck it right into your lungs, and micrograms can do the trick. You won't need more. And what we know about inhalers is that budesonide, which is in the brand names Pulmicort and is paired with salmeterol in Symbicort, is the safest steroid out there. It's an old medicine. If a newborn needs a steroid, he or she gets budesonide. If a pregnant woman needs a steroid, we push for budesonide. And again, this is why it's a good idea to talk about asthma early when establishing care with a physician, so that even if the current asthma plan is fantastic, you can have a plan in place in case conception happens. So one thing that many women do is they stop their controller medicine. So say the Advair, say the Dulera, something like that, because they want to minimize medication in pregnancy. And we already talked about how that can put women and their fetuses at risk. So relying on albuterol or as needed medication can be risky. And so we look for controller medication, and ideally controller medication in pregnancy is budesonide only without a long-acting beta agonist. But we can add salmeterol, we could add formoterol if necessary, because to maintain oxygenation for the pregnant person and the baby to be is what we really want. And the risks of these medications are quite small. So inhaled steroids allow continuous treatment rather than relying on a rescue medicine, which is going to help you for 2 to 4 hours. And again, talking about pregnancy with a primary care doctor or a nurse practitioner or a PA in a general medicine clinic should help anyone move towards a safer pregnancy regimen for asthma. So one thing that doesn't stop when anyone becomes pregnant is environmental allergies, and that those sort of fall into 2 groups, the annoying and the ones that are worse. And if you're a little sniffly when you go over to a neighbor's house and there's a cat, that might be worth just sort of sucking up and dealing with. But if this is something pervasive, cat, when you visit a parent, or grass during that season, and it's going to cause a lot of mucus, it's going to cause discomfort, it's going to cause wheezing, then treatment is essential. And we know from asthma and other allergy research that proactive treatment often means that we use less medication than if we're trying to get on top of symptoms. So this is also a conversation that can be had with the doctor anytime. And when we talk about cat exposure, grass exposure, somebody who's allergic to dust mites and might have headaches every day, budesonide, the steroid of choice in asthma, is also available as a nose spray, and it's available over the counter. And so that's really the best choice. Okay, so food allergies. Food allergies can be dangerous. Most expectant parents would do anything possible to minimize the risk of food allergies. So we'll spend a couple minutes on that. If you are pregnant and you think you're having anaphylaxis, you've got to use epinephrine, because it's true that it shrinks the vessels, but anaphylaxis can cause breathing problems, which brings us back to the early slides, because someone who is pregnant has got to keep breathing to keep the fetus safe. So epinephrine should be used as soon as it crosses anyone's mind, pregnant or not. So if there's any question about whether or not one is having a reaction to a food, to a sting, anything like that, the EpiPen should be used. The risk is so small, but using epinephrine can save the pregnant person and the baby. So we can talk now about the prevention of food allergies, because if you're an adult and you have a food allergy, we're happy to see you here. We have some great studies, but it's not the time to start a study because there's risk with these things. But if you want to prevent allergies in your children, it's best to eat a broad diet and to consume things like peanuts and shellfish and wheat and dairy, eggs, all of the big offenders. So consumption of these in pregnant women is somehow protective. And if someone has no allergies, there should be no dietary restriction. If you are pregnant and you are allergic to something, then that has to be avoided. There was a really interesting paper 11, 12 years ago presented at the Quad AI when it met in Philadelphia. It was a German study, and women who were allergic to peanut consumed sub-threshold doses of peanut. So this is not a study that would happen in America, but they had a dose of peanut every day that was not enough to trigger anaphylaxis. And the babies in the group of women who consumed that sub-threshold dose were much less likely to be peanut allergic than in the group of women who avoided peanut. So you've got to avoid peanut if you're peanut allergic, because this is not a safe place yet. But if you can eat peanuts, that's to be encouraged. What the LEAP study showed is that there is an association between peanuts in the home and peanut allergy, but that's more from siblings and parents touching and kissing babies with eczema or other skin trouble, rather than having it from the mouth and getting that initial exposure through the gut. So if a baby has eczema or any sort of skin problem, that's something to get on top of early, because you want to introduce those high-risk foods, shellfish, fish, eggs, milk, wheat, sesame, as between the window of 4 to 6 months, because that's when it appears to be safest. And in order to do that in the safest possible way, we want the skin to be intact. So if a baby has some transient dry skin between going home from the hospital and 2 weeks, that's really not a big deal. But if the baby is itchy, if the skin doesn't appear to be a perfect barrier, that's something to seek medical attention for, because the upside to treating is so much greater than letting it go. And it also would trigger early introduction of high-risk foods with potentially a really good outcome. So in the realm of preventing asthma, no one should be around tobacco smoke, and that includes pregnant women and babies. And if somebody lives near a freeway or a busy street, there are many programs that can provide air filters, HEPA air filters, and similar products to families. You can go to the American Lung Association site, you can Google Red Cross things, and there will be links that can help. Often a hospital pulmonology department can help with that. And if a family is going to buy a vacuum cleaner, one with a HEPA filter is really ideal. So that's kind of the quick and dirty, and I am happy to take questions. Here's one. Okay, so here, this question is, are there any special considerations that need to be made when using an EpiPen while pregnant? Absolutely not. If you have nut exposure while pregnant and you think this is the real thing, use the EpiPen and go to the hospital, because your baby, especially in the 3rd trimester, has got to keep breathing. You can't take any risks. You can't do it in the 1st trimester. You can't do it in the 2nd trimester. And you're dealing with a big fetus. Are there other questions? We have studies now that look at babies in the womb. We collect samples from pregnant women and hope to be able to answer these questions in a better way with that data. And we also have a study that's recruiting babies who are under 3 months old, whether or not they have eczema, to see about what happens if we try to prevent the eczema. And both of these studies allow early allergy testing for the children involved. And it's kind of exciting, because maybe we'll get the kind of data that means that all of these issues are well controlled and aren't issues in 10 years' time. That would be great. All right, hold on. Here's another question.
We have another question.
Oh, any relationship between miscarriage and allergies in fetus and or mother? There's no known correlation. Miscarriage is a really difficult thing. It's a hard thing for anyone to experience. And it's also difficult because unless someone has more than one in this country, there usually isn't an investigation. But sometimes there's a reason. There's a genetic anomaly, something like that. But there's no data to suggest that an allergy in the fetus would cause a problem. And in environments that are not so Western, allergies really are not known, even for venom stings and for foods. So there's something about the Western experience that promotes allergies, because if you think about it, people have been around for hundreds of thousands of years. They inhabit just about every ecosystem, and we continue to exist. So if allergies were pervasive and struck the young, that would be a big bad thing. We will be doing food allergy testing in the Sunbeam and the Seal babies. So if it's something that you're concerned about, these are good studies to think about. Any other questions?
If you'd like, you can raise your hand and ask your question live instead of typing it out. So feel free.
Ooh. Okay. Okay. What's the question?
Christine has a question.
Hi, yeah, thanks. My question is, you mentioned something about the inhaler and putting your throat back. Is that did you say to do that or not to do that?
Oh, absolutely do that. I mean, think about it. Medication can't read road signs, and there's nothing in the back of your throat with a big arrow. So if you can straighten out the tube and do your great big inhale, that's just better. More medicine is more likely to get where you want it to go.
Surprisingly, I've had allergies and asthma for years, and no one has ever mentioned that. And I also have been taking the inhaled steroid for EOE. Would you recommend that when it's a
No,
swallow
it's
steroid?
different because for EOE, you want it to go down the esophagus. So the technique was different, right? You want to swallow it then.
Right. No, I've been doing that, but even for my asthma medications, no one has ever recommended that.
Well, the thing is, when the asthma inhaler, when it's the kind that you twist to pop, right? Like the Advair inhaler is like that. Then sometimes the dry powder can leak when you hold it up that way. But in general, especially if you're dealing with an aerosol, you want to put your chin up. And it's true, people don't really talk about it, but it is a really rational way to take an inhaler.
Great. Thank you.
Sure. Okay, any antihistamines that should not be used in pregnancy? Ideally, you don't need antihistamines in pregnancy because your symptoms are managed with safer drugs. It is true that Benadryl is sort of the drug of choice if you need an antihistamine in pregnancy, but it's generally not the drug of choice in general because the time that it's effective as an antihistamine is relatively brief compared to the amount of time that the average person is groggy. And so that's not great. Zyrtec is an antihistamine. Allegra is an antihistamine. And these things are not, years ago, we had pregnancy categories for drugs. These things are not the best category. So it's a conversation between you and your doctor about whether it's worth doing this. For the sort of symptoms that we use antihistamines for, especially in asthmatics, montelukast can be a really good choice because that, when it went before the FDA, that was approved for pregnant people. So montelukast is part of the conversation about coming up with a pregnancy appropriate drug regimen. What else?
And then Katie, would you mind putting up the slide if you have it for contacting us, just in case anybody.
Sure. So SNP Allergy at stanford.edu for questions. If you'd like to participate, this is the address.
If there's not anything else, we can end the webinar early. Up to you.
I don't think anyone's going to object. All right.
Thank you, everyone. Thank you.
Take care. Thank you. God bless.